Next is going to be Michael Wilkey from the office, our Director of Compliance, and that's going to moderate a discussion with Anthem, Harvard Pilgrim, and Ambetter. And with that, without further ado, Michael, I will turn it over to you.
Thank you, Commissioner. Welcome, everybody. This panel will be focusing on the markets, on benefit designs, and also on payment reform. This is the first of two panels, and we're very fortunate, lucky this morning to have three distinguished individuals from the three carriers who are operating on the exchange here for 2018, despite the turbulent times, despite the uncertainty that exists in today's world as far as healthcare goes. We have Dr. Bill Brewster from Harvard Pilgrim, we have Lisa Guertin from Anthem, and we have Chris Kennedy from Ambetter from New Hampshire Families. So welcome. What I'd like to do is just kind of talk about some of the parameters for this discussion. Each of the questions and each of the topics that will be raised are very broad in nature, and in fact could probably take up the entire day if in fact we were to go into details on each one of them. So we've asked our distinguished guests this morning to really be brief and precise in their responses to the questions. Again, it's going to be about 45 minutes. We have asked each of the panelists here also to refer, to read through and kind of refer in their responses to the article in the New England Journal of Medicine by Dr. Schratt. Each of you had the opportunity to pick up a copy on your way in this morning. At the end of this particular panel and the questions, we will have a few minutes, I hope, to be able to answer questions from the audience. If you have questions, we would really ask that you fill out the card and just kind of wave it over your head, and somebody will be by from which to be able to pick it up and be able to answer to ask those questions of the panel. So with that, let's begin. And I'd like to ask each of you, we're just going down the road, is to really kind of introduce yourself, your position within your organizations, and talk about the markets that your companies are focusing on here, and not only historically, but also as we go forward here for 2018. So welcome, please. Dr. Cruz.
Thank you. I don't know if any of you saw me writing down distinguished on here. My mother's still upset that I'm not a real doctor anymore, and so I'm going to tell her that not once but twice I was referred to as distinguished this morning. So thank you. So I'm an internist by training. I was the medical director at Harvard Pilgrim starting about 5.5 years ago. Before that, I practiced in New Hampshire for longer than I care to admit, because that would make me old. But I have had an internal medicine practice. I also have worked most recently in an occupational medicine and walk-in clinic where we saw a lot of people that weren't covered by insurance. So I've seen the transition over the time, and I still work there on Saturdays on occasion, and have seen the effect that having insurance for more and more people, and the positive effect, I think, but also the effect with co-pays and deductibles and that kind of thing on the let's make a deal kind of process that I do when I write the prescription and then tell them to have the pharmacist call me or call me when they get there if for some reason they can't afford the drug, because it's not only the co-pays and co-insurances and that kind of thing, but just the brute cost of even the generic drugs that come out. So I am, for about the last 1.5 years, the vice president of the New Hampshire market. Sales reports to me, contracting reports to me. I have an incredible team, and I'm not just saying that because I have some of them sitting here. But again, thankfully I have a team because there's been a lot going on in the market that requires some really smart people at all of our companies to really think about, again, how do we provide the best care in an affordable way so that people that have insurance can participate in the market. And as somebody said, the new people in the market get educated about what kind of rights they have to the kind of health care that I've been fortunate enough to have for years as part of an employer-based or something I bought from my practice. As far as focusing on the different market segments, that was a question that came up, and I basically asked everybody, and I said, do you feel differently than I do? Do we focus on a particular market segment? And my staff reassured me that it wasn't just me that thought. We really look at all of them. They're all important. They're all important to to pay for themselves. And they're important but different. Each one of them takes a lot of work to figure out what the benefit plans have to be, what the pricing has to be, and what the risk is. So I think we focus on all of them, most recently expanding into Medicare Advantage, which is an HMO-like product that gets us into a market segment in a state, as somebody said, that is aging. and a market segment that I think we see a lot of potential in. So that's our latest focus for market segments.
Okay. Good morning. I'm Lisa Guertin with Anthem, and I've been with Anthem for almost 28 years. It'll be 28 years in January. Holy cow. And I've been the plan president since 2004 with a brief 3-year stint when I stepped away to take on an assignment for our corporate parent, Anthem, Inc. And I think most of you are familiar with our structure. Anthem is the second largest insurer in the United States, and we operate the Blue Cross plans in 14 markets, and because we believe that what we do is so inherently local, each of those markets has a plan president like me here on the ground, and a large workforce as well serving our customers. I think when it comes to the question of what are we focusing on, I think kind of inherent to who we are is we are all things. So Anthem's been around a long time, and we really do serve all segments of the market, and have for some time. I mean, I had to laugh when I saw that blue pie chart up there in 2014 on individual when we had 99% market share because we were the only one. But we've been in the individual business for many years, even pre-ACA, as well as, of course, the group business, all segments, small, large, fully insured, self-insured, specialty lines, Medicare Advantage, federal employee programs. So, I mean, it's just really, I think, a piece of who the Blues are, and certainly who we are, that we focus on the entire market statewide. And while I would say, as Dr. Brewster said, we give attention and unique attention to the needs of each of those segments, I don't think there's any getting around the fact that the individual market has been quite a handful and quite consuming. In fact, I have a little rule among my leadership team. We can't, when we're talking about our segments of the market, we can't start with individual because it gobbles up all our time and we don't get onto anything else. So it has been a handful with all of the changes, but not because it's more important per se, just because it has been so volatile and dynamic. So look forward to talking about some of that with you today.
Well, thank you, and thanks, Mike, and thanks to the department. It's really great to have the opportunity to be here and with these other two very distinguished individuals, as we pointed out. But if you're not distinguished, I'm not even in the room.
That's the third time.
So my name is Chris Kennedy. I'm Director of External Relations for New Hampshire Healthy Families. And in that capacity, I really serve as a primary director of our strategic partnerships. And I also have the real privilege to, on a day-to-day basis, serve as the primary interface with our stakeholders, being our regulators, healthcare associations, of course, the Department of Health and Human Services with our Medicaid product, and of course, public policymakers and lawmakers. And so, prior to that, I've been with the company about 2 years. So prior to that, I had the great fortune of working in Governor Maggie Hassan's administration, where I served as Director of Legislative Affairs and Policy and eventually Deputy Chief of Staff. And that was really the beginning of my education on healthcare, and obviously at that time, during the governor's term, we were focusing on many of the same challenges and dilemmas we're focusing on today. And so it's great to continue to be a part of this conversation in a bit different capacity. But obviously I come to this discussion a bit through the guise of the public policy side of the discussion. But toward that, as I mentioned, New Hampshire Healthy Families is our health plan. It's based in Bedford, New Hampshire, where we have about 170 employees. And we first came to New Hampshire in 2013, primarily, exclusively as a Medicaid managed care organization. So we contract with the Department of Health and Human Services to serve the state's Medicaid population, where we have just over 60,000 members. In addition to that, we have our commercial product, Ambetter, which I'm here today to talk primarily about, which focuses exclusively on the individual market, where we have about 17,000+ members. And you'll hear me reference a lot of key repetitive themes maybe today, but one of them is that our experience in the individual marketplace, in particular with the premium assistance population, we do serve both premium assistance and the FFM population, but our experience and our approach is, I think, very much shaped by our experience as a Medicaid managed care organization. And so maybe that's a little bit something unique about us, aside from the fact that we do really in New Hampshire at this point focus exclusively on the individual market.
Thank you. First question that I'm posing to the group here is I'd like you to discuss really how cost sharing is expected to influence consumer behavior, not only in today's market but in the future. We heard from Department Actuarial this morning in Jen's presentation, everything else like this, the claim PM levels to include the cost sharing components and costs for the premiums associated with those claims. How do you see this going forward? And we see all kinds of different co-pays, deductibles, co-insurances that are out there in today's marketplace. How do you see this going forward? And maybe we can start and just go through. And Lisa, would you like to start that particular piece? And I'll hit all of you. Don't worry.
Sure. Yeah. Thank you. Well, I guess broadly, I would say that I think multiple studies have borne out that cost sharing does impact utilization at all income levels, and I think there's a reality check here. Arguably, if you can't pay the deductible and you can't, is it still going to influence your behavior? I think there's a certain reality that we have to accept and manage within. But I would say, generally speaking, as it relates to utilizing health insurance and health care, we believe that people need a way to know how much things cost and a reason to care how much things cost. And that reason to care can take the form of cost sharing, which I don't think of as a penalty. I think of it as a proportional share of the costs. And if you go back in time when a lot of plans had co-insurance, it was just that. It was a proportional share of the expense that you incurred. And then I think for simplicity and as managed care took hold, we moved to more predictable co-pays, but they do still tend to sort of track with the overall cost, where an office visit will be a relatively low copay and a surgery might be a higher copay. So there's this concept that it really is intended to be the consumer's share of the cost that's being incurred, and I think that's important to help drive cost-effective choices. I think more and more we've realized that people tend to think of that as the stick, and as front-end deductibles get larger and larger, and I'll talk about that later because that's one of the questions I think we were asked to contemplate. What are some of the concerns we have about benefits going forward? And just the sheer size of deductibles is certainly one of them. So I think we believe that in addition to cost sharing that actually it is variable depending on the consumer's willingness to make cost-effective choices, there's a place for the carrot as well as the stick. So we've really moved pretty aggressively to have incentive-type programs. So it's not just you can avoid cost share if you make a cost-effective choice, but you can actually get a cash incentive if you will consider your options for a certain type of service and choose one that's high quality and low cost. So I think that combination of incentives, cost share, and information has to be an important part of keeping the consumer engaged in their decisions. So again, just to sort of restate, cost sharing does impact utilization. I think it has an important part to play. I think we need to be mindful about the sheer amount that we're asking folks to pay, but it's an important strategy overall.
Chris, the population, Ambetter, New Hampshire Healthy Families has dealt, primarily with the premium assistance population over the past year, and they're expanding out, in full force into the commercial marketplace for 2018. How do you see the cost sharing impacting today's marketplace?
Yeah, Mike, I agree with a lot of the key themes that Lisa just raised. I would say first and foremost at Ambetter, philosophically, we don't want cost sharing to represent a barrier to access to care, right? We want our members to receive access to care and access to care at the appropriate time in the appropriate setting. So I think obviously you referenced, we serve a lot of the premium assistance population. A lot of those folks are kind of removed from some forms of cost sharing, and they can be very premium sensitive. But I think, what's important first and foremost is whether you refer to it as carrot and stick, it's an opportunity for us to make our membership aware of the costs of healthcare, as I think was referenced before a question was asked. Especially when you're talking about the premium assistance population, you're talking about a membership that maybe hasn't had access to the broader healthcare system before in the past, or at least in quite some time. So bringing them back and acclimating them to the broader healthcare system and helping them understand the cost structure of our healthcare infrastructure is important. But again, we focus a lot on the incentive side too. One of the things we do, that kind of navigates cost sharing and incentives is one of our plans on the marketplace. We offer no cost sharing at all to our members for the first 3 visits to the PCP. Because obviously that's the kind of relationship and that's the kind of point of access to care that we want to, first again, reacclimate our members to, especially in that PAP population, but also foster that relationship. In terms of incentive programs, we have what we refer to as our Cent account that does offer those financial incentives to do and to undertake healthy behaviors. So whether you're talking about an annual physical or you're talking about going and getting your flu shot, basic fundamental healthy behaviors like that we found have been effective with our membership.
Dr. Brewster, any thoughts, additional thoughts?
Well, I mean, again, I don't want to repeat everything that Lisa and Chris have said already. I think I would agree in large part with what they said. We're concerned that deductibles are really a blunt instrument, and unfortunately can affect the lower income people more than it would affect the higher income folks. And what we're concerned about, not only because we have a lot of clinicians working there and we're concerned about the patients, but we're also concerned about just the reality. I mean, even if you thought we were brutal, heartless, just saying no, insurance payers, why would it make sense to have anybody not be able to afford to get care early? Why would we not want people to go and get their screening tests or see their PCP who can pick up on something when it's this big instead of that big? So we balance the need to have the patients have some skin in the game to understand that things cost money and they cost a lot of money, but really trying to make sure that we design products and systems that help people out. We have something called Save On, where actually if you call, I have it wrapped around my card because even I forget to call, but if you're getting a certain test, you call the Save On, there are nurses there, you can ask them, would this be less expensive someplace else? For calling, you get paid. If you actually move to a different site of service that's lower cost, you get paid more. And we actually have the nurses there that will help call the doctor and move that around, because there is work to it that's almost overwhelming if you're in the middle of an illness or a test and you don't want to upset the doctor. We also work with our Benevera partners so that we're coming out with a zero copay for as many PCP visits as you want to see somebody that year. It's $0 if you see one of our Benevera partners, some of whom are in the room today. And we also work with the provider partners on product design, because it doesn't just affect the patient, it also affects the providers. What if you have bad debt? What if it's a gazillion dollars out of pocket? What if you can't collect that as a provider? That raises costs up. So we really want to think about that kind of thing as well as part of our partnership and how it affects providers. I mean, aside from me being one, we get them to say, you're not thinking about this. So I guess I'll end there. But.
The next question has to deal with, really on the benefit design features and whether you see there's anything that's impractical or unacceptable out there. And let me kind of preface by saying that I'm much older than anybody here at the table. I have seen benefit designs that kind of, raise my eyebrows over my entire career. And in looking at some of these summary descriptions that are out there for cost sharing, for tiers within the tiers, pharmacy benefits with 4 different tiers now, some of them, and really kind of redefining the generic and brand and where they fall into place within the pharmacy tiers. Where's it all end? I mean, we want transparency. We want people to be able to use the benefits, especially to your early onset and getting treatments. How's this looking? And I'll let anyone who wants to volunteer to answer that to start that.
Yeah, so I'll just jump in. First, we wonder why people have trouble navigating our healthcare system, right? The complexities are so vast. But, I'll just point out, I think in a broad sense, philosophically, I think we at Ambetter view benefits design philosophically the same way we look at cost sharing mix. Really, ultimately, it's about, first and foremost, making sure it's not a prohibition to access to care for our members. Ultimately, we want to drive our members towards accessing care at the right time in the right setting. Those are the most cost-effective points of care. And so, again, just philosophically, whether we're talking about benefit design or we're talking about cost sharing, ultimately, first and foremost, we need to look at whether or not that is serving as a prohibition to our members accessing the care they need at the time they need it. Because if it's not doing that, ultimately you're defaulting to, either undesirable forms of utilization or worse yet, no access to care at all that amounts to the most costly aspect of this entire equation. So from a philosophical standpoint, I think we're really focused razor first on in particular with our population, again, that we're still working with very much to get acclimated to help navigate the insurance marketplace.
Do you think we're headed in a direction, Chris, and follow that, where legislation will be necessary at some point in time to guide the cost sharing and what can be done and the network designs?
Well, Mike, as somebody who engages with the legislature regularly, I am certainly reluctant to put any ideas out on the table. But I will only say, listen, I think we have several different discussions ongoing in the state of New Hampshire, including I see Representative Rosenwald out in the crowd, who sits on the PAP commission, of course, along with representatives from the insurance department. I think, listen, we're having a robust public policy discussion about a number of things, including benefit design, including cost sharing, all those aspects. We really need to find the right mix of to best serve our members and ultimately fulfill our goal, which is creating better healthcare outcomes.
I feel strongly about this one, so I'll jump into. I mentioned already that I think one thing that is concerning is just the sheer size of the general deductible, the front-end deductible, where I think we've seen the percentages in the Gorman report, which I thought was excellent, and it really shows, what percentage of people, really in all segments of the market, have deductibles above $3,000 or even above $5,000. Mm-hmm. And when you think about what percentage of families in our country will never have $5,000 in their savings account at any point in time, I think it's clear that, it's a problem. The alternative to that simplistic, blunt instrument, gigantic deductible is these inherently complex tiers. And I think you see it mostly on pharmacy for obvious reasons, because we just saw in the report that pharmacy is such a powerful cost driver that the benefits have sort of naturally evolved there to try to create those incentives to get to the cost-effective choices. And it is complex. I agree with you. I never thought I would. I've been doing this business for a long time. I never thought I'd see 4-tier anything in a drug plans.
Are we headed to 5 tier?
Probably, yes. But so I think that's inherently complex. But I think there are reasons for those designs have evolved. I do think with the variation that exists in cost for the same drug agents, or for that matter within healthcare delivery in general, and I think once again the Gorman report gave us a very good scan of that. I think they reported that the most expensive hospital in New Hampshire is 2.5 times the cost of the least, and on the physician side it's 2. And I think that actually understates it, because by type of service that variation can be even wider. So I think we should and we have to have cost shares differences and designs that reflect that. That's a little bit more complicated, but I believe it's also a way to take unnecessary cost out of the system. So I think that's a balancing act. I hope we don't get legislation. I think it's important that we keep our ability to be flexible in trying to control cost. And I understand that at some point that's a possibility, but again, I worry about it. I think even the ACA itself has tied our hands in some ways in terms of benefit design possibilities. It's not all bad, but I would just hate to see us race down that road further.
Yeah, and I just wanted to weigh in, again, not to repeat everything, but I would agree. I think one thing everybody needs to remember is that this is about medical care, and it costs a lot of money. The more the technology changes, the more things I can do. I started in medicine with 3 choices for blood pressure medicine. I mean, there's 3 different versions of the same medication now. So it's gotten expensive, and if we legislate things that aren't based on evidence, that they aren't based on medical kinds of things, I think legislation where it level sets the field so none of us are disadvantaged, and it says, okay, you need to cover screening tests. They've been shown to save lives and save money. I mean, I'm okay with that. I think that level sets it. We're all in it together because it's about price. I mean, it's what people can afford and pay for. But I'm really concerned when there's legislation that really says you need to cover things that don't have evidence-based medicine behind them but on the basis of any independent organization or doctor organization, that if you really think about it, that may raise those deductibles and may raise the premium price, where suddenly a small employer goes, I'm just not going to cover insurance. So I think we have to walk that fine line between legislation that protects people, level sets, and things that really just raise the price with no evidence behind it. So that's my concern.
I think from the department's perspective, we're getting more and more questions and have over time, is people really not understanding what their cost sharing requirements are, getting surprised in billing, and they didn't realize that, the deductible would kick in, or they have a collection notice from a hospital or a particular provider and what to do. So it is very increasing, and that could be responses to those. Thank you. In the New England Journal of Medicine article by Dr. Schreit, she speaks really to some of the Medicare initiatives, the CMS initiatives, really, as far as some payment reforms. She does get into the discussion a little bit on ACOs and all, but also really kind of talking about the margins and the pharmacy costs. What's being done out there, and what are the plans for the future from which to be able to really get at some of these cost areas, to be able to help curtail maybe what be unnecessary prescribing or administration of particular drugs? Then we talk about cancer, drugs and all. What can be done out there? I mean, what's going on out there? What are you folks working on? What are you seeing? What would you like to see?
Yeah. Well, I think, like everything, providers, patients, and payers need to come together to figure out what can we afford, what are reasonable guidelines for prescribing medicine. We've been working with Dana-Farber in Massachusetts on following NCCN, the National Cancer Collaborative Network, guidelines that say these are the first choices, these are the drugs you use, these have evidence behind them, and that when you're experimenting and doing things because somebody's desperate, that's a trial. That's something that the drug companies should be helping pay for, not something that we should pay for. And so we're working with them to say, you know what the right things to do are, you know what the guidelines are, and we'll reward you if you follow those kinds of guidelines. I think our work with Medicare Advantage to have people actually follow, get to their PCP with an HMO-like product, take the advice of the PCP, get the kinds of things that, the advice about what are the next steps. And again, going back to Venivera Health, having people, our social workers, community health workers, working with people about navigating the system. We have, step edits, we have first choice drugs. Again, I think if you're Medicare, now I always think it's always easier for somebody else, but I think if you're Medicare and you account for the lion's share of somebody's business, you can come in and tell people to do whatever you want to do. And I don't know, that's not what we're taking. We're really trying to partner up and say, okay, we all can agree on certain things. How about if we follow those guidelines? We'll reward you for that with risk contracts where we share in the premium dollar and get you to really think about what you're spending as a physician. For years, I can tell you as a physician, I was really not supposed to know what kind of insurance they had, what kind of copays they had, other than a formulary where I had this thing on the wall for Anthem and Harvard Pilgrim and whatever, and I'd go, okay, I need a nasal steroid, which one's on that formulary? Other than that, I didn't know it. I have seen the change in the medical director meetings that we have twice a year in our office, where docs are actually caring, like I do on a Saturday, where I go, I can't keep track of what things cost for you, but I will work with you to get out of the choices the drug that's going to cost you less, and don't be embarrassed to call me back if the drug I write is unaffordable, because I know you won't be able to take it, call me. But it's that conversation that docs have to have about patients, recognizing that there is an out-of-pocket and there are hurdles outside of just pick the right drug or the one that you saw on TV to use for people. And I won't start on direct-to-consumer advertising.
Please.
You okay?
Yeah, sure.
Okay, well, so I think your question, Mike, about just what's going on with the CMS trial and what have we learned from that. I actually heard recently that this particular trial is being canceled based on some pushback from pharma, and I'm not sure if that's
There's quite a push.
quite a push. Yeah. What I would answer that two ways, I guess. In general, I do think we watch carefully and learn from what CMS is doing, and that's very much reflected in our pay-for-value program, which is called Enhanced Personal Health Care, which also has really strong roots right here in New Hampshire with the medical home pilot that was done some years ago. I think both Medicare ACO, Pioneer ACO, and the medical home pilot here really informed our program, which has been very successful because it's focusing on the primary care physician and their important role in working with the patient to guide their care throughout what can be a very fragmented system. So I think we're always really mindful of that and staying in kind of close alignment with Medicare's policies and procedures. I think specific to this particular article and the talk about drug payment reform, it's an area where we would agree there has to be more attention. If you think about especially infused drugs and how they're being paid for, and the costs that are sort of leaching into the system at each stop, it's something we're focusing on as well. How can we get the very best possible? These are life-saving drugs, but they are shockingly expensive. And once again, the variation in cost, depending on where you get it, can be fourfold, sixfold. And so having an ability to get those drugs on a drop ship basis at a very effective price point into an office for the patient to receive is the kind of thing that we're thinking about. Right. So again, I believe that those strategies are going to play an increasingly important part, because you saw that specialty drugs, which have been a problem for some years, have now actually moved up into the largest category of spend within pharmaceuticals, and we don't see that changing anytime soon.
You bring up ACOs as the article and medical home, and it's kind of these are terms that are out there, but we haven't heard really. At least I haven't, and I think I could safely say for most of the department, some of the successes associated with the ACOs and the medical home out there. Is it really paying off? Is it really something that you're grasping hold of, and is impacting the quality of care as well as the cost of care?
Absolutely. For us, our program that I've mentioned called Enhanced Personal Health Care, we wanted to design a program that would focus on primary care, building on what we learned from that medical home pilot, that would work for the smallest practice, a one-person practice, all the way up to the most sophisticated system, hospital-owned system, Dartmouth Hitch, with both gain share opportunity, and then as you progress up that spectrum, downside risk as well. I think we're in our 6th year. The savings are in the millions of dollars, 5% of total claims, with quality improvements. So I do think enhancing and working differently with primary care, and that means incentives and value-based payment, but it also means new information and tools and collaboration. I do think that is critical. I just think the programs are so important, and we're seeing great results coming from them.
Chris?
Yeah, I don't want to repeat things, but I would agree. I mean, I think everyone's focused on an integrated care model, and I think Ambetter, we're very focused on payment reform, payment innovation, and obviously it's centered around quality. It's centered around utilization direction. It's centered around outcomes. And Bill and Lisa could probably speak better to maybe Medicare as a driver, but frankly, the motivation, the momentum around driving down costs is a driver, and so I think we're all looking at that first and foremost and primarily.
Bill, anything to add to that from an ACO and you mentioned it here, and the work that Harvard has been doing along those lines for utilization and management?
So I've said the word Benevera several times, and Benevera Health is a company that we started with Dartmouth, Elliott, St. Joe's, and Frisbee about 2 years ago. It'll be 2 years January 4th when we went live. But it's been a process that's engaged these partners, these provider partners, for a long time. And that and some of the other support we've done with grants for patient-centered medical home in other hospitals in the state really has gotten, and the risk contracts we have, has gotten people to really have skin in the game and really share. We share our total population dollars and risk across our 4 partners in Benevera Health. They are very much involved in the decisions, the concerns, and just, I will tell you, having negotiated with payers on the other side of the table as a medical director for our Physicians Association in Rochester for a number of years, to come in a room where we share openly the good, the bad, and the ugly about what we each do, to really work on not competing on things we don't need to compete on, not have 2 sets of people doing the same thing and confusing the patients, really makes a big difference. So whether you call it an ACO, whether it's value-based contracts where everybody gets that there's only a finite amount of money out there. The employers cannot afford to have that bar graph go up, so we go up even further. And we need to work together to figure out how do we keep people healthy. And the back end of that's going to be medical costs will go down.
The part of this discussion and part of what we asked you to think about too is that, and we see it in the PAP program, we see it with Medicaid, with wraparound benefits, is really, as you get into kind of a population-based type model, what do you feel are the obligation of yourselves as carriers to that population type approach, as well as, how do you see that kind of, impacting the way you do business? Please.
I see it as a partnership. I mean, we would describe our program as not just a payment innovation or pay for value program, but a collaboration program. I think what works best is when every party trying to solve a problem brings the best of their expertise to the table. And I think we really need to respect that patients, our customers' relationships, first and foremost, are with their caregiver. And I think it makes perfect sense for us to empower and frankly reimburse that caregiver for doing more to take care of their total health. It's one of those things when you step back from the system we've all created together and you think about things like really until very recently, a primary care physician got paid for one thing and one thing only, and that was FaceTime with the patient behind the curtain. So all the things that they needed to do to manage that person's total health, maybe they're a poorly managed diabetic and they really need some extra time and planning, that was all off the side of their desk at night on their own time. That doesn't make good sense. And so this idea that we would start to give primary care physicians a payment, a per member per month payment, designed to help them enhance their practice. Maybe they're bringing in a care manager, maybe they're extending their hours, but it just reflects that there's more to caring for a patient than just that 5 or 15-minute appointment that takes place. The other thing we can really bring to the table is, besides incentive and reimbursement, is information and insight and tools. And if you're a very large, sophisticated practice, you probably don't want to use our tool. You have your own, you just want our data to feed it. But if you're a small practice that hasn't been able to make those investments, maybe you like to use our desktop tools or our tablet tools. So it's flexible in that regard. And once again, if you stop and think about common sense, if you're a primary care physician, unless we're giving you that information, how would you know if your patient had been to 13 different ERs in the past month? You wouldn't. So I think, again, we're trying to each say, let's do our part and let's meet in a collaborative way to serve the patient, because there are things that you can do better and there are things that we can bring to the table to make that work. I think that's the vision of what success looks like.
Yeah. So I'll just add, I obviously agree with a lot of what Lisa said in terms of shared responsibility there. I think, as carriers, we I don't know that I'll call it an expectation, but frankly at Ambetter, it's our business model. We have a real role to play in care coordination and ensuring that our membership, in working with our providers, in working with social service agencies, in looking at and bringing our resources to bear in terms of data and looking at social determinants of health. It's really placing an emphasis on care coordination at a heightened level is something that frankly we should be doing better and better, and we should be engaging in directly with our members and providers. Again, I think I can't emphasize enough that I think insurers and carriers are moving away from I guess that conventional dynamic, that conventional understanding of what insurance carriers are. They administer and pay claims, and moving really more towards care coordination entities. And I think, as we encounter increasingly complex populations, I think it's really incumbent on us to do that.
And just to comment also, I mean, I've said Benevera a lot, but one of the things that I think, you know, as we're a not-for-profit, we have, I think that helps us in some way be, you know, have a little bit more leeway to do some things that are outside the norm, perhaps. And I think what Benevera Health is all about is actually doing things that occur outside the doctor's office, that population health kind of thing. We've invested millions in this, both in the technology and the dashboards and the information we have about where everybody's going all over the place, not just when they're seeing you as their physician, but so we can give that information back to people. But when we hired and as we've morphed over the last 2 years, we have a majority of the people in Benevera Health that actually go out to the patient's home. We'll do a visit with them in the doctor's office. We'll go with them to a mammogram. Are not nurses. They're not the traditional care coordination, which we still do, that has to do with making sure the right knee's operated on, the right drug is taken, or whatever. Those things, again, patients go, well, that's just lights on. I'm not going to give you credit for not operating on the wrong leg. But what about all the other things that keep people from getting a ride, the things we all deal with, all the social aspects? So we have community health workers, social workers, to help them deal with it's the opiate abuse, the spouse that has the opiate abuse, the job situation, all those kinds of things that probably drive 80 to 90% of the success I have as a physician in the office when they leave me. And that 15 minutes or a half hour they have, what about the rest of their life that we really work on? That I think that population health, getting out there, whole person, in person, to say, we look at everything that's going on, that I think is really the next frontier to really change the costs and help people navigate beyond just when I'm seeing them for those few minutes.
If I might just add, you know, I think Bill touched on something. I think it's particularly imperative as we collectively navigate and address the sudden opioid crisis. I mean, I think, you know, care coordination in that context is imperative as we look at these members that have, you know, increasingly complex needs, increasingly diverse needs. You're talking medical health, you're talking behavioral health, you're talking, you know, social service needs. And so I think carriers have a real role to play, and increasingly we should play these roles in coordinating the care. You know, Bill referenced again the case managers that we have within our plans, the care coordination staff that actually are going with members to primary care visits and other provider visits, but also working with them to help them access those social services that may be other social determinants in their healthcare landscape. You know, housing is a key one, working with social service agencies that may focus on housing, because we know, by the way, that stable housing is an absolute imperative to successful recovery and treatment with SUD.
Right.
So.
Well, thank you very much. I'm glad this 45 minutes went by very, very quickly. And